Dr. Jamie Benham. So she is an assistant professor in the Department of Medicine and Community Health Sciences at the Cumming School of Medicine at the University of Calgary, and she's an endocrinologist with Alberta Health Services. In her clinical role, Dr. Benham provides comprehensive care to patients dealing with various endocrine disorders. Her primary focus is on women's endocrine health, particularly in managing conditions like polycystic ovary syndrome and gestational diabetes. Her research centers on exploring reproductive and cardiometabolic health throughout life for people affected by these reproductive endocrine disorders. She's dedicated to uncovering the complex connection between hormones and health with the goal of improving patient well-being and community health. Dr. Benham completed her bachelor's degree in exercise science and earned a Doctor of Medicine degree from the University of British Columbia. After this, she underwent clinical training in internal medicine and endocrinology and metabolism at the University of Calgary. Dr. Benham pursued a PhD in epidemiology at the University of Calgary. She then furthered her commitment to endocrinology by completing a Royal College accredited clinician investigator program research fellowship. And her research journey was supported by a Dr. Fernand Labrie Fellowship Research Grant from the Canadian Society of Endocrinology and Metabolism. Looking forward to your talk.
Thank you so much, Dr. Thompson, for the introduction. I will just share my screen here. Can you see that okay? Perfect, thank you. So thank you very much for the invitation to speak this morning. I'm going to be talking about polycystic ovary syndrome and cardiovascular disease risk. I do apologize, I'm a bit under the weather, so I'm going to do my best to maintain my voice for the duration of this talk. And I wanted to talk about this topic because as a clinician, I see a lot of women with polycystic ovary syndrome in clinic. And this question has been coming up a lot as to what is my risk for cardiovascular disease. So I wanted to do a little bit of an update on the literature and share a little bit about what we've been working on. So I'll start just with some disclosures here. So I will be talking today about the 2023 clinical practice guidelines, and I was a contributor to these. And then in terms of inclusion, I aim to use person-first and inclusive language in this presentation. So if you notice anything that I could improve on, I would appreciate if you'd send me an email to let me know, and my email is listed there. So let's begin. What is polycystic ovary syndrome? So polycystic ovary syndrome, or PCOS, is a heterogeneous and complex reproductive and metabolic disorder that affects between 9 and 13% of reproductive age women. There are a lot of reasons why people affected by PCOS may present for care. And these include some of the things shown in this figure here. So there may be a history of acne or weight gain or excess hair growth. But overall, when we're looking at how we make the diagnosis of polycystic ovary syndrome, we're looking at 3 main criteria. So affected individuals may have a history of irregular menstrual periods, which means less than 8 menstrual periods per year, or menstrual periods that last less than 21 or greater than 35 days. They may have high levels of androgens when we measure in the blood, or they may have clinical evidence that they have high androgen or testosterone levels with things like acne or excess hair growth. And if an ultrasound was done of the pelvis, there may be evidence looking at the ovaries of polycystic ovaries or enlarged ovaries, which may suggest PCOS. And for a little bit of context, the total cost of evaluating and providing care to reproductive age women with PCOS in the United States in the year 2020 was estimated at $8 billion. So how does PCOS manifest? So it's characterized by a number of different changes in the functions in the body. So there's evidence of excess androgen production, high levels of circulating insulin. There's a disconnect between how the hypothalamus and the pituitary speak to the ovaries. There's an increase in sympathetic nervous system activity. We see low-grade inflammation, and there's abnormal function of adipocytes. And one of the central features of PCOS is insulin resistance. So hyperinsulinemia and insulin resistance, seen here in the middle, are seen in between 60 and 95% of people with PCOS. But despite its prevalence affecting up to 13% of individuals, it is a diagnosis that doesn't occur very often. There is significant underdiagnosis, with only about 50% of women who meet the criteria for having PCOS having a recorded diagnosis of PCOS. And the reasons for this are likely multifactorial. It may reflect a lack of awareness among affected individuals and healthcare providers about the condition. And it may also indicate that only women with a more severe phenotype, meaning symptoms that are more bothersome to them, consult a healthcare provider to receive a diagnosis. So among women with self-reported PCOS, so they diagnose themselves with PCOS based on criteria, in Ontario, many experienced dismissal of symptoms by healthcare providers and had negative diagnostic experiences that they reported in a qualitative study published in 2021. And reasons that have been identified by females living with PCOS for this diagnostic delay that they're experiencing include that PCOS symptoms are not taken seriously by their healthcare professionals when reported, and that medical professionals are often less knowledgeable about PCOS than females themselves with lived experience. This negatively affects the doctor-patient relationship and has been demonstrated that compared with females without PCOS, those that are affected by PCOS report less trust in their primary care providers. In a survey including 1,381 women who had self-reported PCOS that was done internationally, they found that establishing the diagnosis of PCOS involved 3 or more health professionals and took at least 1 year. There was also a negative association between the time to diagnosis and psychological well-being in these survey participants. There are many reasons for delayed diagnosis in this population. These include no single diagnostic test, a need to exclude other reasons that people may be presenting with the symptoms that they have, and there are different sets of diagnostic criteria to diagnose this condition. Given these challenges, comprehensive care of PCOS in a multidisciplinary setting, like a multidisciplinary clinic with specialties like dermatology, gynecology, endocrinology, nutrition, exercise physiology, and psychology is widely advocated, but few of these centers exist, and we certainly don't have a center like this in Alberta. And the author's conclusion from their survey findings was reported delays in diagnosis suggest missed opportunities to optimize treatment and improve quality of life. So what matters most to people affected by PCOS? In this same survey, they asked participants what it was that they were most impacted by. And the top 4 reasons are listed here: difficulty losing weight, irregular menstrual cycles, infertility, and excess growth. So as an endocrinologist who's interested in metabolic health and how this syndrome impacts metabolic health across the lifespan, I'm interested to see that just over 10% of individuals surveyed were concerned about their increased risk of metabolic risk, shown there with the arrow. What about in Canada? We see a similar story in Canada when we look at the concerns that people with PCOS have. So this survey was recently conducted. It was an online questionnaire carried out in Alberta to assess the perceptions of health status, healthcare experience, and disease management support. And this research was led by Dr. Donna Vine and her team based out of Edmonton, and they included 194 participants living in Canada, 93% of which were from Alberta. And the main concerns that participants had in this questionnaire were body weight issues, irregular menstrual periods, infertility, and hormone balance. The concern for type 2 diabetes was much lower down here at the bottom at 8.2%. So what is the association between cardiovascular disease risk factors and polycystic ovary syndrome? So we know that PCOS is associated with the development of adverse cardiometabolic sequelae, including excess weight, impaired glucose tolerance, gestational diabetes, type 2 diabetes, dyslipidemia, high blood pressure, and metabolic syndrome. And these are all risk factors for the development of cardiovascular disease. But while the increased risk of developing these cardiovascular disease risk factors is recognized, the risk of developing cardiometabolic risk factors may not apply equally to all people affected by PCOS and may be mediated by many patient-level factors such as family history, age, body mass index, ethnicity, and PCOS phenotype. And what I mean by that is whether an individual has high levels of androgens or androgens within the normal range. Those people may have different levels of risk depending on those patient level factors. So what about excess weight? Excess weight is a common feature of PCOS that affects individuals across the lifespan. It is estimated that 61% of adults with PCOS have overweight or obesity, which varies by ethnicity as well as by geographic region. And obesity is associated with worse reproductive and metabolic outcomes in this population. The risks of overweight are approximately 2 times, of obesity approximately 3 times, and central obesity, which is obesity around an increased abdominal circumference, is approximately 2 times in women with PCOS compared to those without. In terms of blood sugar and dysglycemia, we see that individuals with PCOS have an increased risk of impaired glucose tolerance, type 2 diabetes, and gestational diabetes. This risk is approximately 3 times higher in women with PCOS compared with those without. And recently, a population-based study in Denmark found that type 2 diabetes diagnosis occurs at a younger age in those with PCOS compared with those without. So they found that the median age for PCOS for developing type 2 diabetes was 31, compared with those without PCOS, which was 35. The risk of developing these abnormalities in blood glucose regulation differs by ethnicity, with the highest odds of developing impaired glucose tolerance occurring in those of Asian ethnicity. And the risk of type 2 diabetes is higher in those who have high androgen levels versus those who have normal androgen levels. What about blood pressure? Hypertension risk in those with PCOS is almost 2 times that in those without PCOS, although this increase in risk may not be consistent across the lifespan, because we do see that with age, the prevalence of hypertension increases among females, whether they have PCOS or they don't have PCOS. And when we look based on whether hypertension is occurring in the reproductive years or later, we see that there is a difference. So the pooled prevalence of hypertension in individuals with PCOS compared to those without has been reported as higher during the reproductive years, 15% versus 9%, but this difference isn't seen after menopause, with the difference being 49% versus 40% in those with PCOS compared with those without. In terms of dyslipidemia, studies have reported that those with PCOS have increased levels of triglycerides, low HDL cholesterol levels, high LDL cholesterol levels, and high non-HDL cholesterol levels. And these changes exist regardless of what an individual's body mass index is. Metabolic syndrome is another important independent cardiovascular risk factor, and metabolic syndrome includes the features shown in this figure here: low levels of HDL cholesterol, elevated blood sugar levels, high blood pressure, excess weight in the abdomen, and high levels of triglycerides. The risk of developing cardiovascular disease is elevated further when there are multiple cardiovascular risk factors that are seen, and the risk of metabolic syndrome is approximately 3 times higher in those with PCOS compared with those without. And when compared based on BMI or body mass index, there's an increased odds of metabolic syndrome observed among individuals with overweight or obesity, but not in those who do not have excess weight. So this is something to continue to watch out for with all of these different manifestations in terms of cardiovascular risk. And there has been increasing recognition that female-specific conditions, including pregnancy-related complications, are associated with the development of cardiovascular disease. For individuals with PCOS who experience pregnancy, the risks of adverse pregnancy outcomes such as preeclampsia, gestational hypertension, and gestational diabetes are increased, and adverse pregnancy outcomes are associated with an increased risk of cardiovascular disease in later life. And these associations support that an underlying pathophysiology exists in these individuals that generally raise the risk for metabolic complications that may culminate in cardiovascular outcome. PCOS is also associated with reduced health-related quality of life, depression, anxiety, and sleep disturbance, which has been observed to increase during the menopausal transition. And sleep disturbance among women with PCOS is associated with an increased risk of having changes to cardiometabolic biomarkers such as body mass index, blood pressure, glucose levels, and lipid levels. Psychosocial distress, including depression, has been associated with the development of cardiovascular disease. So what happens for individuals affected with PCOS across the life course? So the phenotype of PCOS, the things that individuals present with and signs and symptoms that they're bothered by, changes over the lifespan. There's a change in androgens, ovulatory function, and ovarian morphology with age, which can complicate the diagnosis of PCOS in adolescents and older reproductive age women. PCOS tends to remain stable only during early adult age, between the ages of 18 and 30 years. But after that time, changes in ovarian and adrenal function and in metabolic regulation modify the presentation of the syndrome. There are few studies in which both women with PCOS and controls are followed longitudinally from early reproductive age into menopause, so there remain many questions in this space. But when we look at infancy and childhood, daughters of women with PCOS have a greater follicle complement and mild metabolic abnormalities from infancy. And there's an increase in anti-Müllerian hormone, or AMH. AMH levels are used to assess antral follicle count because levels are highly correlated with antral follicle count on ultrasound and reflect the number of small antral follicles in the ovary. Metabolic abnormalities include increased leptin levels in cord blood in infants and a decreased insulin response to glucose prior to puberty. During puberty and adolescence, the signs and symptoms that characterize PCOS overlap with signs and symptoms experienced by all females undergoing puberty and may require some time to establish whether this is reflective of PCOS or not. Adolescents with PCOS all experience acne, irregular menstrual periods, and increased ovarian volume. So it can take some time to make this diagnosis in this population, but should be suspected if individuals are experiencing these symptoms. During the reproductive years, ovulatory function improves with age in women with PCOS. Menstrual frequency increases with approximately 30% of older reproductive age women developing normal ovarian function. But throughout the reproductive years, we see the hallmarks of PCOS, which are hyperandrogenism, irregular menses, and increased ovarian volume and follicle number. Females with PCOS present to healthcare providers at different points across their lifespan, depending on the symptoms they are experiencing. And some, as was mentioned earlier, may never present for medical care. But we do see that with weight gain across the lifespan, there's an exacerbation of both reproductive and metabolic risks. What happens as we enter the late reproductive age and menopause? With aging, studies have demonstrated that clinical PCOS signs and symptoms, including menstrual irregularity and polycystic ovarian morphology, may improve. There's a decrease in ovarian volume, there's a decrease in the number of follicles, and we also see that the androgen levels may decrease. The reproductive lifespan is longer in women with PCOS, with an estimated age of menopause 2 years later than women who do not have PCOS. And when considering menopausal hormone therapy in those affected by PCOS, clinicians should consider the high cardiometabolic risk in this patient population and target menopausal hormone therapy options appropriately. But in terms of what we see from a hyperandrogenism perspective, this does improve with aging, such that individuals with and without PCOS who did have statistically significant differences in androgen levels during their reproductive years may not have that anymore as we enter the postmenopause phase. PCOS diagnosis can be considered post-menopause if there is a past diagnosis or a long-term history of irregular menstrual periods with a history of hyperandrogenism or polycystic ovarian morphology during the earlier reproductive years. All women, as they enter late reproductive age and menopause, experience increasing insulin resistance and abdominal adiposity, along with chronic inflammation and dyslipidemia with age across this time. While some differences exist, most metabolic parameters are the same for women with and without PCOS at this life stage. There are several hypotheses as to why the metabolic disturbance that exists prior to menopause doesn't exist after. So one thing is that there may be lifestyle interventions in those identified to have PCOS that leads to treatment in this patient population that reduces the risk of cardiovascular disease risk factors due to early treatment and prevention, leading to less clinical cardiovascular disease events and mortality. Another possible explanation is that there is a later age of menopause in those with the history of PCOS, which may lead to greater cardioprotective estrogen exposure. And finally, there's a thought that women without PCOS develop cardiovascular risk factors in menopause that are observed in women with PCOS at a younger age, including increased weight, waist to hip ratio, fasting glucose and insulin resistance. And with these metabolic changes observed during menopause, women without PCOS essentially catch up to women with PCOS in terms of their risk of adverse cardiometabolic outcomes. So what about cardiovascular disease and PCOS? This is a question that I do get in clinic quite often. While many women with PCOS have risk factors, for cardiovascular disease, studies to date have revealed mixed findings when it comes to the association between PCOS and cardiovascular disease. There have been several meta-analyses completed which have looked at this association, many of which were published in 2020 and are shown there on the slide. So one of these included 166,000 individuals from 10 cohort studies, and it found that the odds of cardiovascular disease, myocardial infarction, stroke, and ischemic heart disease were all increased in women with PCOS compared with those without PCOS, although they didn't find a difference in mortality related either to cardiovascular disease or overall mortality. A second meta-analysis included 16 studies compared with 10 in the other meta-analysis, and found that the risk of cardiovascular disease, including coronary artery disease, myocardial infarction, ischemic heart disease, and heart failure, was increased. However, when they limited only to population-based studies, which was 12 out of 16 of the studies, they no longer found a significant association between those who were post-menopause, but they did find a significant association for those who were of reproductive age. Another meta-analysis included 23 cohort studies, and they found no association between PCOS and coronary disease events, but they did find an increased risk of non-fatal cerebrovascular disease. So overall, this is fairly confusing when trying to explain to patients what this risk between PCOS and cardiovascular disease is. And there's a number of limitations of studies included in these meta-analyses that's examining this association, including that there are different study designs, many of which were cross-sectional studies. There's small sample sizes. Variable diagnostic criteria has been used for diagnosing PCOS. The definition of the population control groups have been different. In many of them, there's a lack of consideration of confounding factors and a lack of longer-term follow-up into postmenopause. Some important exclusions were that individuals weren't included who had a self-report of PCOS, which is found to be fairly consistent with individuals who are also then diagnosed by a healthcare provider, or that medical records from some of these meta-analyses precluded the inclusion of data from large population-based studies. In 2023, there was a meta-analysis that looked specifically at cardiovascular disease in those over the age of 45. And they found no difference in cardiovascular disease for just over 1,200 women with PCOS, compared with almost 6,000 controls in 7 studies. The authors did, however, find that there were increases in the risk of myocardial infarction and stroke. Overall, though, they found that the confidence and the certainty in these findings using the GRADE tool was of a very low level. And certainly they were limited, that the studies were heterogeneous, of low quality, used variable definitions of PCOS, and had small sample size. So the question as to whether cardiovascular morbidity and mortality is increased in this population needs further exploration, as women with PCOS are exposed to these cardiovascular risk factors for a longer duration, and it's not clear if this predisposes them to a higher risk of cardiovascular disease after menopause. For the update of the clinical practice guidelines published last year, they did a new rigorous evidence synthesis, systematic review, and meta-analysis to include studies using PCOS of any definition for the most comprehensive and representative data. And the results of this study revealed a 50 to 70% increased odds for cardiovascular disease, including angina, myocardial infarction, coronary artery disease, revascularization, peripheral vascular disease, stroke, transient ischemic accident, and cardiovascular disease-related deaths. And the risk of myocardial infarction was 2.5 times higher in women with PCOS compared with those without. And so therefore, the recommendation from the PCOS guideline is shown there on the slide. It now recommends PCOS being recognized as a risk factor for cardiovascular disease, and that all women with PCOS should be assessed for cardiovascular disease risk factors. The certainty of the evidence, though, shown on the right side of that slide, is very low, which indicates that there is very little confidence in the effect estimate, and that the true effect is likely to be substantially different from the effect of the estimate. So this still leaves us with a lot of questions as we counsel individuals with PCOS about what this true association is. What do we know about PCOS and cardiovascular disease in Alberta? This study was published earlier this year. It was a retrospective cohort study that used administrative health data available in Alberta between 2002 and 2018. And it included individuals aged 12 years or older with PCOS determined using ICD-9, 10, and not ICD-9 and 10 codes, and individuals were matched by age. In this study, they found that the prevalence of hypertension and cardiovascular disease was 30% higher in those with PCOS compared with the control non-PCOS population, and that peripheral vascular disease and cerebrovascular disease had a 50% and 40% higher prevalence in individuals with PCOS compared to those without. These diseases occurred on average 3 years earlier in those with PCOS compared to those without. And so they also saw that there was an increase in myocardial infarction of 40% higher in this patient population, with a new diagnosis occurring at 43 years in individuals with PCOS compared with 47 years in those without PCOS. So why would an individual with PCOS develop cardiovascular disease? There are several mechanisms that may contribute to the development. Certainly, we see in this population that there is abnormal sympathetic nervous system activity. Adipose tissue function is changed, including adipocyte hypertrophy and apoptosis. There is low-grade inflammation that has been observed. There's impaired endothelial function, which is another crucial marker of cardiovascular health. And the development of cardiovascular disease, as we've talked about, may further be exacerbated by traditional risk factors for cardiovascular disease, like excess body weight and diabetes, which are known to be associated with PCOS. There is evidence of early atherosclerotic disease, and markers of early stage atherosclerosis, including coronary artery calcification and carotid media intima wall thickness, have been reported. So what are the recommendations for screening for cardiovascular disease risk factors in this population? So in the most recent guidelines, there's a highlight for assessing for cardiovascular disease risk factors right from the time of diagnosis. And there also has been a recognition that in this patient population, weight stigma is a major concern in healthcare and in other settings. And so one of the first steps in thinking about assessing for cardiometabolic disease risk is certainly considering weight stigma education and minimization strategies. The guidelines suggest promoting weight-inclusive practices, such as asking permission to discuss and measure weight, blind weighing, and availability of appropriate equipment, but it is suggested that screening for excess weight be completed at the time of diagnosis and then at regular intervals with healthcare providers. In terms of dyslipidemia, the screening interval for the lipid profile is to be completed at the time of diagnosis, and then it subsequently depends on the patient's underlying risk factors, like whether they have also a history of diabetes or excess weight, and their global cardiovascular risk. Hypertension, measured using blood pressure, should be completed at diagnosis and annually, and updated in the latest guidelines is that this should also be assessed when planning pregnancy or when thinking about fertility treatments. And finally, impaired glucose tolerance and testing for blood sugar regulation in individuals should occur at the time of diagnosis and then every 1 to 3 years after that. And they do recommend using a 75-gram oral glucose tolerance test if available, to get the best representation, because we often see that the response to a glucose load is impaired before we see any changes in the fasting plasma glucose or in the hemoglobin A1C. The more frequent assessment should be completed in those who have a family history of diabetes, a personal history of gestational diabetes, advanced age, or obesity. And so one of the major questions that we've been looking at as a part of our research program is what's happening in terms of this screening? So we have recommendations that exist in the guidelines, and these have been in place. They continue to evolve with specific recommendations, but these have been in place for some time. So what's happening in terms of what's being done in practice? So a cross-sectional survey conducted in 2015 among 157 gynecologists in the US revealed that while most respondents were aware of metabolic abnormalities in PCOS, most providers were not following cardiometabolic screening guidelines available at the time of the study. When the survey was administered, all of the practice guidelines related to endocrinology and gynecology for PCOS recommended a 2-hour oral glucose tolerance test to assess for glucose intolerance, yet more than half of respondents reported that they would never order this test. And more than 20% of providers were not ordering any metabolic screening tests for 50% or more of their patients with PCOS. When the respondents were asked about the interval at which they would repeat any of these cardiometabolic tests, there was wide variability in the practice. And so this study highlights that there's a gap in implementation of clinical practice guidelines that exist for assessing these cardiometabolic risks, and that there's room for improvement in terms of cardiometabolic screening in this population. A more recent survey of doctors from New Delhi who were attending an international endocrinology conference in 2019 and were from different specialties found some similar results. So these individuals were asked 30 multiple choice questions. And overall, they found that there was significant heterogeneity in PCOS treatment practices among doctors of different specialties, as well as they found that they were detecting different areas of PCOS. For example, depression in PCOS was more likely to be detected by pediatricians, and that different practitioners were using different types of treatments for PCOS. So endocrinologists and gynecologists were more likely to use hormone pills to manage PCOS. Metabolic complications of PCOS were more likely to be screened by endocrinologists and general physicians, and nearly 1/4 of the doctors frequently evaluated for serum insulin levels in women living with PCOS. So while raised serum insulin may be a marker of insulin resistance, routine use of serum insulin in clinical practice is discouraged because we rarely get any new information that would help to change clinical practice. This test is more relevant for research purposes and for epidemiologic studies, but the absolute values of it have limited utility from day-to-day clinical practice. And lipid profile testing as a screening method for dyslipidemia was not routinely conducted in this study in women with PCOS, with only almost 13% of doctors routinely screening for lipid abnormalities. In Australia, a recent cross-sectional study of 146 general practitioners and general practitioners in training was performed to evaluate barriers and enablers of uptake of PCOS guidelines in practice. And they used this model, the capability, motivation, opportunity, behavior model, or the COM-B model, to assess how this can be brought into practice. We have a guideline for PCOS, which is long, has many pages, has many recommendations. How does this get implemented into practice, and how well are they doing in Australia? So the authors noted many of the barriers to implementing these guidelines into practice that are listed there on the left. So there are inherent barriers that prevent physicians from integrating evidence for PCOS into their practice. And the author's conclusions from this is that there is a lot of work that needs to be done to implement evidence-based guidelines into practice in a meaningful way. And these need to occur at the policy level, at the community level, in the individual practices, to be able to facilitate the translation of this. When we think about cardiovascular disease prevention in this population, there are a number of things that we can do. So certainly recognizing that PCOS is a female-specific risk factor for cardiovascular disease is imperative. We need tools uh, to be developed that we can use to effectively quantify the risk to guide clinical management. Many patients that I see in clinic tell me that they receive a diagnosis and they're told that they should come back at the time when they're wanting to get pregnant and that there's nothing to do in the interim. So we need to have an understanding of what this risk is and what we should be doing throughout the reproductive years that's not related to fertility. Screening for cardiovascular disease risk factors should start at the time of PCOS diagnosis and continue across the life course based on underlying risk factors. And we can address modifiable cardiovascular risk factors like smoking cessation for individuals who may be smoking, encouraging exercise, reducing sedentary behavior, and healthy eating, all of which are recommended among individuals with PCOS from the time of diagnosis, given this increase in risk. We know that lifestyle interventions, including behavioral strategies like goal setting, dietary intervention, and exercise are helpful in this patient population. We also know that 5 to 10% weight loss is associated with significant clinical improvements in individuals with PCOS. And healthy lifestyle behaviors are recommended to optimize health and quality of life, as well as to maintain and or achieve a healthy weight. In terms of specific exercise recommendations, exercise is recommended in all individuals to treat PCOS, but the most effective exercise prescription is not clear. Preliminary evidence suggests exercise may be beneficial in the management of PCOS in terms of improved anthropometric and cardiometabolic health, menstrual regularity, ovulation, and health-related quality of life. But currently the recommendations are consistent with those of the general population. So to maintain health and to prevent weight gain, it's recommended that individuals with PCOS participate in 150 minutes per week of moderate intensity physical activity, and that muscle strengthening should be completed 2 days of the week on non-consecutive days. So in conclusion, PCOS is a complex metabolic and reproductive disorder that affects approximately 13% of females. The presentation of PCOS changes across the lifespan, making diagnosis difficult during adolescence and menopausal stages. And the management strategies that exist for management of individual PCOS symptoms and sequelae work, but we need a better understanding of the condition to further tailor this treatment and provide individual risk assessments for cardiovascular disease. So with that, I will take the opportunity to let the university community know that we're recruiting for a new study looking at blood glucose levels in individuals with PCOS measured using continuous glucose monitors to give us a better idea of what these look like in individuals who do not have diabetes and whether this can be used for the diagnosis and management of PCOS. So thank you very much for your attention. And with that, I will stop sharing and I'm happy to take any questions.
Thanks, Jamie. That was a very clear and informative talk. So we'll open it up for questions from the audience. You can put something in the chat or raise your hand. While we're waiting, I'll just start with